Hi, I'm Tracy, the palliative care pharmacist at Parkview Regional Medical Center. We are developing a set of modules that can be applied mostly to palliative care patients, but the module today can be applied to any patient in the hospital. The title is called Approaches to Pain Assessment. Okay, let's get started. The objectives of this module are pretty simple. At the end of the video, you should be able to describe the hierarchy of strategy in assessing pain. And then the second thing you'll be able to do is you'll be able to explain which behavioral tool is best to assess different types of patients, like a demented patient, an ICU patient, or a pediatric patient. Okay, let's jump right in. All patients with pain deserve prompt recognition and treatment. Pain should be routinely monitored, assessed, reassessed, and documented clearly to facilitate treatment and communication among healthcare clinicians. We all know that pain assessment and management are components of the Joint Commission's standard of care, and it requires us to screen every patient in the hospital for pain and then follow up as appropriate. Assessing patients and their comprehensive assessment of pain is really the key piece of successfully managing a patient's pain. The effective clinical management of pain depends on how accurately it is assessed. So, how can we as a healthcare provider do a better job? Well, we've established that all patients with pain deserve prompt recognition and treatment. Pain needs to be assessed routinely and documented to make our treatment the best it can be. When you go about assessing pain in a patient, there is a hierarchy or an order that you should go to gather your information. The gold standard or the most accurate tool is asking the patient or having the patient self-report. In a typical verbally responsive patient, you would ask them to rate their pain on a scale of 0 to 10. That's the numeric pain scale that PRNC uses. Then, once you establish that number of intensity, you could go on and gather the details. Where is the pain? How bad? Describe it. What makes it better, worse, etc. The patient's self-report is the most accurate and reliable evidence of the existence of pain and its intensity. Unlike other conditions like blood pressure and temperature, there's no thermometer for pain. We need to have the patient relay to us the intensity of the pain that they're feeling. This 0 to 10 numeric score is the most reliable way to do that. And this holds true for all patients of all ages, regardless of communication and cognitive defects. Even if a patient can't concentrate on this particular pain intensity scale, go ahead and ask them a simple question about whether or not they have pain. A yes or no answer, indicated by nodding, head shaking, or other signs, should be considered a valid self-report of pain. If at all, approach every patient and ask every patient if they're having pain. Even intubated or sedated or demented patients, go ahead and ask them to see if they can self-report. The Ask the Patient 0 to 10 numeric pain scale has been validated for adults and children 10 years or older. Now, there are patients, obviously, that are unable to self-report. All the patients with altered levels of consciousness, sedated patients, patients that are mechanically ventilated, demented patients, and then, of course, throw in the infants and preterm babies. All these patients are unable to self-report. In patients that are unable to self-report pain, other measures must be used to detect pain and to be able to evaluate the interventions that we have. No single objective assessment strategy is sufficient by itself. So we need to combine different methods of evaluating pain in our nonverbal patients. We need to look for causes, we need to use behavioral tools, and we need to ask caregivers and loved ones. So, like I said, we have to gather evidence. We have to gather pieces of the puzzle. Not one single objective assessment strategy is sufficient to evaluate pain in nonverbal patients. So we said if patients can self-report, that's the way we go. If they can't, then we start looking at other avenues of evidence of whether or not they have pain. And one of the first things that I do is I search for potential causes of pain. I look in the medical record. Are there any known pain-inducing pathology that the patient came in with or has? Do they have a fractured femur? Did they break their hip and that's why they're here? Do they have a history of diabetic neuropathy in the lower extremities? Do they have an active infection going on now? Are they having progression of a disease such as breast cancer? All of these things are known to cause pain, and so I would keep that in mind as I went through the rest of my assessment. Are there also common procedures that the patient is undergoing that cause pain? Routine care, suctioning, turning the patient can be very painful. Procedures, inserting a Foley catheter, invasive instrumentation, needle sticks, chest tube removal, these are all considered painful procedures. And even if the patient has wound care, that can be extremely, extremely painful. So search for potential causes of pain in your nonverbal patient and keep that in mind as you go through the rest of these assessment tools. Next, observe patient behaviors. If the patient can't tell you they're having pain, we need to select a behavioral tool and see if based on the patient's behaviors they appear to be uncomfortable or having pain. Behavioral tools have criteria where you kind of grade the patient in pain. Here's an example of a behavioral tool. And you can see on the left-hand side, you look at different indicators such as facial expression, body movements, muscle tension. And then on the right side, you actually give the patient a score for how you feel they look right now. It's sort of like giving a patient a test. You grade them on the various questions, and then you get a total score. And you can see based on that score whether the patient appears to be having pain or not. Again, it's another piece of the puzzle. You can see where if you use the same test over and over, even if different staff are on, they will use the same test. So it promotes consistency among different healthcare providers in using the same tool. You're all assessing the pain the same way. Plus, using this tool allows us to evaluate whether or not we are successfully treating the pain and discomfort. So you use the tool not only to assess whether there is pain, but after you do your intervention, you use the same behavioral tool to follow up and see if things have improved. Now, Epic has quite a few pain behavioral tools built into the system so that you can do your documentation. Let's look at the choices. In the adult patient, you can pick no pain. You can use the 0 to 10 numeric scale. You can use the advanced dementia scale, and we'll look at that in a second. And you also have a choice to put you're unable to assess. In pediatrics and children, we have the same choices, no pain and unable to assess. And we also have the FLAC scale, the NIF scale, and the NCAS scale, which we'll look at in just a second. And then there's the Wong-Baker-Facey scale. Now, I want to take a quick look at the Wong-Baker-Facey scale. Most of us are familiar with it. It's been around since 1983. This tool has been validated to use in children over 3 years of age. It's been validated in older children too, up to about age 17. Now, the proper use of this tool, you explain that each face is for a person who has no pain, some, or a lot of pain. You explain each face, and then you ask the patient to choose the face that best depicts the pain that they are experiencing. So as you can see, this is another way, another tool where patients self-report the intensity of their pain. This scale is not validated in patients that are unresponsive or on a ventilator. And if you go to the website of the Wong-Baker-Facey scale, there's this question that was posed. Leave patients that are unresponsive due to their illness, injury, or medications. Is it possible to use the Wong-Baker-Facey's pain rating scale by comparing the patient's face to the faces on the scale? And their answer on the website is the Wong-Baker-Facey's pain rating scale is a self-assessment tool. The patient themselves must be able to understand the tool and be able to indicate which face most closely depicts the pain experience. This is not the tool to use for unresponsive patients. So in general, this tool is restricted to children. However, it is appropriate to use this scale in maybe an older adult that has maybe a limited education level, or a low health literacy level, or dyslexia, and they're having difficulty comprehending and using the numeric 0 to 10 scale. You can use this tool in those types of situations as long as the adult can self-report. They can pick the face that matches the pain that they're feeling. Okay, so the key to using behavioral tools, and this is an important point, is that you have to pick the appropriate tool designed and validated for your patients. The fact that the Wong-Baker scale is not accurate in non-responsive patients illustrates this point on the slide. If you pick a scale that's not validated for your particular patient, the results or the score that you get using the tool may not be real or right, and they may just not be appropriate, and they really don't tell you a lot of information. The second thing is that you need to acquire proper training on the particular tool that you're using to make sure that you're using it in the correct way. There's a couple infant scales that you're supposed to observe the infant for at least a minute before evaluating and using the tool. Some of the other tools are supposed to be, the patient's supposed to be watched at rest and when they move before you actually assess them based on the tool. So, in summary, you're going to use the correct tool for your patient. Based on whatever score you get, you're going to put a plan into action. And then you're going to reassess your intervention using the same tool. That's the consistent piece to see if your intervention has improved things. And then certainly determine if readjustment is needed and keep going in this direction. Okay. So after you search for possible causes and you observe patient behaviors using a behavioral tool, there's another piece of the puzzle that you can gather information from, and I call it surrogate reporting. That's where you obtain credible information from a parent or another person, caregiver, or family member that knows the patient well. This is called proxy reports or surrogate reporting. Parents and caregivers should definitely be encouraged to actively participate in the assessment of their loved one. Always listen to what family members and caregivers say. This is part of your gathering information. Certainly encourage their comments. This builds trust between you, the clinician, and the patient. However, keep in mind that family and caregiver feedback is often emotional, which may or may not be entirely factual information. Family members do tend sometimes to overestimate pain intensity when compared with patients' own self-reports. So this is just another piece of the information that you're gathering to assess the patient's pain. And finally, we do this every once in a while. We may attempt an analgesic trial in a patient. Perhaps we have a patient and we're just really not sure, even after gathering all of our pieces of information, whether or not they're in pain. We may initiate an analgesic trial with a non-opioid or a very low-dose opioid if we think there may be pain involved, and then we assess them and see if our intervention improved things. If it did, that suggests that the patient did have some level of pain. Okay, so back to the EPIC pain behavioral tools. Again, I have the ones listed appropriately for the adult on the left and then the children on the right. Let's walk through these. We had talked about the numeric rating scale. It's the 0 to 10. Please rate your pain, 0 being no pain, 10 being the most pain imaginable. And you can see how the results 1 through 3 are classified as mild typically. 4, 5, and 6 moderate, and 7 and above is severe. Again, I want to stress, the most accurate data for assessing pain is obtained from the patient. For patients that are able to provide verbal responses, the alternate behavioral tools that we will talk about really shouldn't be used and shouldn't be considered to be substituted for just the plain numeric rating scale. Now, we already touched on who this scale is not useful for. Anyone that is confused, unable to express themselves, unresponsive, and certainly our little pediatric population. Okay, in patients that are unable to respond, the Pain AD scale is the tool that we use in EPIC. Initially, this scale was developed and validated in institutionalized patients whose dementia was so advanced that they cannot verbally communicate the fact that they're in pain. It was validated back in 2003. However, since then, it has also been found to be reliable and valid in both hospitalized post-orthopedic surgery older adults who are cognitively intact, that was in 2008, and more recently, one study validated it in non-verbal ICU patients back in 2011. So you can see how this tool works. Based on 5 different behaviors, you rate the behaviors from 0 to 2, and then you total up the score. The score will range anywhere from 0 to 10. So this is a tool that can be used for your nonverbal, non-responsive adult patients. Now, looking at pediatric patients, we have the FLACS pain scale. FLACS stands for face, legs, activity, cry, and consolability. And this scale has been validated for infants 2 months all the way up to children 7 years of age. The total score, again, you rate each of these categories on a 0 to 2 scale, and your total score is going to be 0 to 10. The neonatal infant pain scale, or NIPS scale, is also a behavioral scale. It's been validated from birth to 1 year of age in both full-term and preterm infants. Again, you score each indicator after observing the infant for at least a minute. You score them based on this pointage and add it up, and the total pain scores on this scale range from 0 to 7. So 7 is going to be the most severe pain imaginable. And then finally, we have the NPAS scale. NPAS is a valid, reliable tool for assessing pain and agitation and sedation in ventilated and or post-op infants 0 to 100 days of age, and all the way down to 23 weeks gestation. It was especially designed to assess prolonged pain, agitation, and sedation in the neonatal population. Now, I said before that there are 2 other options to document an EPIC. One is no pain, and certainly that is a very acceptable documentation because not all of our hospitalized patients have pain as an issue. The second option in EPIC is I'm unable to assess. You can document that you're unable to assess. In my mind, this is really not acceptable documentation under very many circumstances that I can think of. If your patient is unresponsive and an adult, you should be using the Pain AD scale at this time. And really, the Wong-Baker-Pacey scale should not be used in any patient that is unable to self-report their pain. Okay, we all know that there are chronic pain patients out there that can be very difficult to assess. There are some patients, and I'm sure we've all taken care of them, that consistently rate their pain 10 out of 10 for their entire hospital stay. Now, this particular scale, the functional pain scale, is not one of your available choices in EPIC, but you can still kind of go about it using it in your documentation. I'll give you an example. When I have a patient that continually rates their pain 10 out of 10, no matter what intervention that I am doing, I go about in assessing their pain a little bit differently. I certainly do ask them their pain intensity score on a 0 out of 10, but I will also reach for this tool and focus on asking them questions about their functionality. Can they watch TV? Can they talk to guests? Can they use their iPad or computer or their cell phone Or the bedside phone. Can they twist their torso over and reach the phone and talk on the phone? Can they walk to the bathroom? I enter these comments in my documentation. And sometimes I observe the patient first when they are perhaps unaware of me observing and make that documentation. And then I go in the room, ask them to rate their pain, and then I observe how their behavior changes with me in the room. It's just an additional piece of documentation for these chronic pain type patients. Okay, so the conclusion statements that I want to make on pain assessment. Certainly all patients need to be screened for pain at admission. It is crucial to pick the correct tool to get meaningful data for the medical team. Unable to assess is really not acceptable in most circumstances. Excuse me. And the frequency of assessment really depends on the treatment plan. And certainly, as we know, difficult patients require more documentation. Thanks for listening. I hope you stay tuned for our next module. Until then, goodbye.